So instead of going through bios, we thought it would be a great idea to give our panelists the chance to introduce themselves through 3 different questions I'll be directing to them. Starting with Emily, perhaps you could start with your governance and digital health lens based on your recent work on this front in South Australia. Can you tell us briefly about the work you are doing in South Australia in relation to the trial of AI scribes?
Thanks, Isabel, and it's a pleasure to be here. Thank you for welcoming me to your conference today. So a little bit about me. I'm a medical doctor by background. I've also got expertise in public health, and I am non-executive director across 5 boards in the education and health sectors. My expertise really is around where the opportunities are for digital and AI to be able to help drive the changes that we need in the health system to be more sustainable. And my background has been in a number of really interesting projects here in South Australia, including the expansion of our statewide virtual hospital, public partnership with Medibank, now under the Ampler Health Group. The second part of that has been really around, I was the COVID community commander here in South Australia during the pandemic, and as part of that, my portfolio was overseeing the Medi Hotel, so really delivering healthcare services in a hotel setting. I've now transitioned that into supporting now the establishment of a subacute facility in transforming one of our city hotels into a private hospital facility, which has been incredibly interesting. And I took note of the sinks as well. We've had major issues with our sinks, changing over hotel sinks into sinks that can be compliant to then be registered as a private hospital here in the state, particularly to help demand for public patients in our healthcare system. And then probably the final thing, as Isabel mentioned, is my expertise. I'm an associate professor at the New Adelaide University, and we're focusing on the use of AI scribes, in particular around redesigning the workflows for our emergency departments, which, as many of you would probably be aware, emergency departments are very busy, chaotic places and often not set up in the design we need to support patient flow and the clinician interactions. So really our role is to design with our clinicians and our consumers a scribe that follows the patient journey from entry to the triage to the patient either being discharged home or admitted into a physical ward bed. So very exciting work here in South Australia, and I'm delighted to be here on the panel today to talk further about some of the innovations that we have underway here in this state.
Thank you, Emily. Your brief description of your work on AI scribes really resonates with me, and this was through a very recent experience that I had with my daughter having to be admitted to a hospital to undergo a surgery. So it really hit me how much time clinicians spend on administrative tasks, which is taking away from their time with patients. So hopefully with these innovations, this will change. Katie, turning to you. You are a big advocate for professionals being fully utilized with multidisciplinary care models for better overall outcomes. Can you tell us briefly how your leadership in health service strategy and planning in Queensland Health, and also your role on the Exercise and Sports Science Australia intersect?
Yeah, thanks Isabel, and good morning everyone. It's great to be here today. So my role in the Department of Health and our team and system planning branch is to help support and drive the health service planning agenda for Queensland Health, and that includes supporting our hospital and health services and partners in effective health service planning to ensure that we've got safe, equitable and evidence-based care for Queenslanders. And we certainly adopt a medium to long-term horizon or view in that planning activity to ensure that we can be adaptable enough given evolving trends in healthcare and health service utilisation, new technologies and new ways of delivering care as well. And in doing that, we evaluate the health needs of the population and then align service delivery both currently and into the future accordingly with that. And that helps ensure that we've got a needs-based and an evidence-based approach to healthcare. And given we've got a scarcity of resources and challenges around workforce capacity, a huge infrastructure pipeline and emerging digital technologies, it enables us to align that and equitably distribute that across the state based on need as well. And in terms of my role at Exercise and Sports Science Australia, it's provided me with a really acute understanding of the interconnectedness between tertiary and hospital-based care and the broader health ecosystem, and how increasingly it's really interdependent. So Exercise and Sports Science Australia, or ESSA, is a peak professional allied health association representing university qualified exercise and sports science professionals. And my role as Vice President there is to help to drive our strategy around building workforce capacity and capability and harnessing that skill set across the health ecosystem, both in hospital and primary care. And we're seeing increasingly an impact of complexity of the regulatory environment and the challenge that places on small business and business providers, and ensuring that we can maintain sustainability of private practice and primary care, given the cascade impact that that can have where there is thin markets or market failure on, for example, ED presentations and hospital demand. So for me, I'm seeing a cross-pollination of seeing the workforce and how we can build that capacity and capability in that particular area, and how we can drive evidence-based health service planning as well.
Thank you, Katie. I always think that allied health professionals are the glue for multidisciplinary care models, so it's always really interesting to see like all the efforts put in this space to improve health outcomes for patients. Anita, you bring a fascinating perspective from medicine, engineering, and change management. You are also known at Health Infrastructure New South Wales for your passion about driving change through understanding the different elements which impact on adoption of change and system-wide transformation. Could you tell us briefly about your recent work at HI in leading initiatives that would have longer impact on design of care models and physical infrastructure across the state?
Thank you, Isabel, and thank you everyone for having me. So I have a unique background in that I'm dually qualified. So I'm an engineer by trade, and I was working as an engineering manager for over 10 years before I came into medicine. I'm also a medical doctor, and that combination allows me to see change management from start to finish, really. One of the things I'm really passionate about is a program called Smarter Hospitals, which is the program of works that I manage with Macquarie University and HI, Health Infrastructure New South Wales. And Smarter Hospitals is about looking at that change management perspective, looking at evidence-based approaches to integrating virtual care or digital models of care into our health system. Now, the next iteration of that is change and innovation. And when you hear change and innovation, you think, oh, those are random words put together. But really, innovation in the corporate sense is about transformational change. And we're seeing this particularly with the new technologies that are coming into the health sphere. So that means artificial intelligence, but also artificial intelligence, particularly in the built environment. So how we're using that in the architectural world, in the engineering world, in the design world, will go downstream into how it's going to influence our hospitals in the future. And so when we talk about change and innovation, it's about managing how those innovations will be integrated into our health system in a seamless way as possible. And change is really hard. Change is really hard from the beginning, and change is really hard at the end when we're looking at the evaluation of that change as well. So I'm really passionate about looking at that from beginning to the end.
Thanks, Anita. Truly incredible. Like I'm really honored to be joined by the three of you. Impressive professional backgrounds and a lot of insights you would share today. So our next phase is the panel discussion. I'll ask an individual question for each of you, and you're welcome to share thoughts. And then at the end, we will wrap up with some key takeaways before we give it back to the audience for questions. So Emily, starting again with you, how can digital tools, including AI and data collection and analysis, generally impact on patient care and clinician well-being, and more broadly, on the strategic investment in health infrastructure?
Well, the reality is that we need innovation to be able to bring about change in the healthcare system. The sustainability, particularly in the public sector, will not be achieved without the use of new tools and the use of digital innovation to support us in the growth and the change that we need. And if we look at the role of AI, I mean, certainly my experience both here in Australia and in the US has been the role of AI is incredible to transform the journey for the patient who's in a physical hospital. And at the moment, we really focus on the front end and the virtual front door. And I say this in my role, I'm on the Health Direct Australia board, where we're really focused on the virtual front door and 1-800 Medicare for Australia next year. What we see is there's opportunities in virtual and digital capability really to support patients in accessing the right care at the right time. But where we're missing that piece really is about physically in a hospital bed, and where can those digital tools support you in a way that doesn't disrupt the flow of how the clinician cares for the patient. It really enhances and elevates the consumer experience and supports safe discharge. So, for example, if we look at ambient scribes, we've seen now that 40% in Australia of primary care practitioners and GPs are using an ambient scribe in their practice. Now, that's a phenomenal piece. In 12 months, we've seen rapid adoption of using an ambient scribe to be able to capture the information between the GP and the patient and be able to synthesise that into a case note, into the medical record. What we're trying to do now is look at how can the hospital system embrace this technology in a way that's safe, that supports patient privacy, but also works with the current way that we operate as clinicians in the hospital system. And that's where the biggest challenge is we're so used to having had either paper records and seeing still a large majority of private hospitals are still paper-based, to then adopting an electronic medical record, now electronic health records. And now we're in this position where we know there's incredible innovation happening in primary care. We're seeing it happening particularly in the US around patient-controlled electronic health records and where that enables the use of AI to be used in real time. But we haven't quite got there in Australia yet. And so our challenge and our mission really within the university and through the Australian Institute for Machine Learning has been how can we look at the current workflows to be able to reduce clinician time and enhance the consumer experience. So really a proof of value that can actually go down into detail as to what it is that we are trying to benefit through the health system. So our metric is we need to save 30 minutes per shift of clinician time entering physically into a medical record through the use of an ambient scribe. And through that ambient scribe, can we then provide more real-time information back to the patient who's either physically in the bed or ready for discharge? And we know currently that the way our hospital flows work, it can take generally up to 7 days sometimes for a patient to receive their discharge summary, for instance, which may contain really critical details that they need to be able to avoid coming back into the hospital, but also to provide care at home, either through family, nursing support, or follow up with their GP or specialist. So this is where it gets really quite challenging. If we don't have the workflows right, where can we build AI and digital tools to support that? So our focus has been, can we build a scribe that's built on public data in South Australia, held within a secure environment that enables us then to build a comprehensive case note for that patient coming in with their interactions with the administrative workforce, with an allied health professional, with a doctor, with a nurse, and build that into one comprehensive case note. Now, nowhere else is doing that currently that we're aware of, having multiple interactions into one single scribe and generating a single output. And what we've even built into this scribe here at the Machine Learning Institute has been the capability to actually translate that information into consumer-friendly language. So it's very simple for the consumer, for the patient, for their family to understand those really quite complex medical discharge summaries into something that is actually at the level and pitched to the level it needs to be for the community to understand how they can best care for themselves in that post-follow-up phase from being admitted. So there's some exciting things happening in the AI digital space, but we have to be really clear that to do this, we need to look at what we're currently doing and what is the problem we're trying to solve. And for this particular problem, it's been clinicians spend so much time documenting in the medical record. How can we reduce that time? But at the same point, we know we're all using different medical records, some paper-based systems. How can we make simple changes that are effective to improve that overall workflow in the hospital system?
Spot on, Emily. And I think as well another point is data collection and analysis and how much it can as well help in predicting the future and improving how we do things through the learning we are collecting and analyzing. So, yeah, thanks. So from a digital innovation to workforce models, my next question is for Katie. beyond digital tools, what workforce innovations or transformations do you think will make the biggest difference? And what do you see our health system could do better in terms of workforce?
Yeah, sure. And I think, to the point of digital, we certainly have this rapid emergence of new technologies, but the real challenge we see ahead is about how we can drive the change management and the capability uplift, the reskilling of the workforce to effectively harness those technologies. So certainly at Exercise and Sports Science Australia, and what I'm seeing across allied health more generally, is a big strategic focus on that digital upskilling of our workforce to ensure that that technology can be safely and effectively harnessed. But certainly from a workforce perspective, the challenge we're seeing in Queensland, which I think is mirrored across probably all states and different jurisdictions, is around workforce capacity constraints. We have a huge demand challenge ahead of us with ageing population, increased complexity and scarcity of resources. And in Queensland, we've certainly forecasted that between now and 2032 a need for 46,000 additional workers in the health system, of which about 34,200 are health qualified professionals. So this is about a 30% increase on our current workforce. So it's a big ambition and it's needed. We have a significant infrastructure pipeline with over 2,000 additional hospital beds committed, which will need the workforce to deliver those services to those beds. But the challenge I really see is the retention. So yes, we do need to attract and compete with private and other employers for this workforce, but we need to be able to retain what we've already got. So about 20% of our workforce are reaching retirement age over the next couple of years. We have pockets and areas in Queensland where attrition rates are worse than during peak pandemic period. And we've got increased challenges around around staff safety and wellbeing in the workplace too. So how we can continue to provide an employee value proposition to our workforce to be able to retain and harness their skills into the future is key. The second piece I see is around the productivity opportunity. So again, about working with what we currently have and how we can extract the most effective impact from our existing workforce through productivity uplift, of which digital and technology is one key enabler to do that. But what I'm increasingly seeing the value of is how we can push the change agenda and traditional thinking models, and how we can explore new scope of practice models that are safe and effective for our patients, but effectively, again, harness the full breadth of our healthcare workforce and the skills that we have in multidisciplinary teams. And one example I've seen, which did have its challenges, was around my team working and supporting with hospital and health services in Queensland to establish nurse-led walk-in clinics. Now, this had many learnings and lessons as part of the process, but it is an example of adopting a curious mindset that's still evidence-based and partnerships-driven to deliver care differently by utilising our nurse practitioners to deliver care for non-life-threatening injuries and illnesses in the community, and in particular targeting vulnerable populations. So those populations that might be disengaged or not interacting with the traditional health system structures until they're so sick that they presented an ED, for example. And so through partnering with 4 hospital and health services, we established this new service. And for those who are familiar with Queensland geography, 2 of those clinics are based quite rurally and regionally in Gladstone and Gympie, where there was poor primary care access, challenges around GP access, and we've certainly heard and seen the value of establishing that service, utilising nurse practitioners to reach people who otherwise wouldn't be serviced. So for me as well, it's around retaining our current workforce by providing that compelling employee value proposition to keep our workforce engaged, and secondly, by driving that productivity agenda through new ways of working and different models of care.
Yeah, I mean, the new ways of working, like the example you provided for nurse practitioners in the community, it really inspires me because most of the time innovation stems from necessity. And this is where we are pushed to think differently and to address these challenges. And most of the times, the solution is not really expensive. It's not like always, we need to spend a lot of money on coming up with innovations. Sometimes these are very simple things. Some changes in how we deliver care, which I'm pretty sure Anita is going to address more in the next question. And then all of this, leads to better patient outcomes and also staff satisfaction. So thanks again, Katie. Anita, anything? Sorry. So. Just lost my question. What example of collaborative approaches have you seen drive real transformation in healthcare?
Yeah, I think the underlying thing that we're hearing out of this is change management is usually categorised into three areas, which is people, process, and technology. And I want to emphasise that technology and spaces or rooms and processes and the hospitals that we develop are actually enablers for the problems that we need to solve. And I want to emphasise that because in the beginning, on the onset of a project, we often think about the space, the design, the construction itself. However, we really need to focus on what are the problems we're trying to solve, and therefore, what are the metrics of success that we're going to deliver out of this. So when we talk about benefits realisation, it's not the end game. It's actually at the beginning. We actually understand who we're trying to benefit, what are the benefits, what are the KPIs, are they measurable in the long term, and also, what are the key problems we're trying to solve. At the core of this, in terms of change management, is people. And we're hearing this from day to day. It's about clinicians, it's about patients, it's about the journey from end to end, and all this is centred on people. So from my experience, what I've seen is the people part of things requires executive sponsorship and what we call change champions. So an example of this I can provide is something we're really excited about in health infrastructure is that we're doing AI in the built environment in a new way. This is a new thing that's coming from all the data we're collecting. So the architects, our construction staff, our design staff are telling us they're using AI tools, and we at Health Infrastructure are developing an AI design framework that evaluates these tools to understand the people, process and technology side of things, and are we getting the return on investment? So to bring people along that journey, the first thing we got to do is actually educate. So our executive are holding for the first time ever an AI-driven design showcase in the next couple of weeks, putting together case studies that are really exciting of architects, the designers, people in the local health districts, what they're doing, to look at patient flow, digital twins, and AI design tools that they're using. So that's that education piece to bring that sponsorship and bring that empowerment into the public health. The next part of that is a journey. It's a journey of building that value management framework and that evaluation framework. So these tools that we're going to be using with our consultants and our vendors, are they going to provide us the value that we want? Are they going to solve the problems that we want? So that framework is going to be essential to how we integrate and use these tools in the future. So we're really excited about that.
Thank you, Anita. I always believe to get the best outcomes, collaboration is really needed, and especially collaboration between industry and government. So it's really exciting, as you said, to see this initiative at Health Infrastructure leading the way. So great points. I think we're a bit ahead of time, and we have a little bit of time to expand on some of the points you've discussed earlier. So before we wrap up, would you like, Emily, to add any insights to what was said?
I think this is something really important around when we think about the workforce and the collaborative piece, and we look at the design and how we are ensuring that our workflows, our consumer experience, the clinician experience is elevated to the highest it can be. It's just amazing, the opportunities and the technology now that can uplift that capability. And the New South Wales Government has put a lot of effort and work into how AI can support and uplift its capability. And as Anita was saying, there is so much that we have been doing over the last decade that's really put us so well in this position, particularly around the use of data and informatics. And And we see now this, positioning of each of the states and jurisdictions and mirroring what's been happening, particularly in the US, around control centres or command centres, and that was really elevated through COVID, whereby we have central coordination of functions across statewide health services or at jurisdictional health services or at a local health district level. And it's fascinating just how that data is used. And in particular, if we look at, what is happening in each of the states, so we predict, we know that we need another 1,000 beds in this particular area. We need 2,000 beds that we have to uplift our capability that we've just heard now. Where is the opportunity to use that data and information that we have now at a statewide level and at a national level to actually predict and be able to enhance our learnings? And digital twins are one of the areas that we've seen some investment in, particularly in both the public and the private sector. GE Healthcare have been really leading a lot in the digital twin space around how we can mirror and map the flow of patients through a health system, but actually how can we better predict what it is that we need over the next 5 years so that we do have the right number of beds in place. Are we elevating our virtual infrastructure sufficiently whereby we have patients receiving care in their home? And that's where I've seen probably the shift in the data, particularly at a public level, virtual hospital care. We've seen it Queensland, New South Wales, South Australia, Victoria just announced last week their virtual hospital being set up through Royal Melbourne Hospital. This is where the future is about care in the home environment, but also how do we get the balance right between physical bricks and mortar care, home-based care, and where acuity can sit in a well-designed and well-planned healthcare system. So I just want to emphasise the data is absolutely fundamental, because if we don't have good solid data and we don't have teams really planning and mapping where the beds need to be, the acuity for those beds, and where patients can receive the right care, right time, right place in their home where possible, we are going to absolutely head towards impending disaster of our healthcare system in Australia if we don't look at where we can diversify and look at how that care is delivered.
And I can pick up on a couple of those points too that we're seeing play out in Queensland. Excuse me. So there was two key challenges that we were facing, and that was in terms of harnessing AI, there was a distinct disproportionate use across the system. So some hospital and health services having the digital capabilities, the IT infrastructure, EMR, perfectly positioning them to start to harness those technologies, and those other hospital and health services who might not have those resources at hand being disadvantaged. So in addition to that, also a lack of guardrails in terms of how we want to harness it in the context of health safely and effectively, keeping clinician wellbeing and patient outcomes front of mind. So with those two key gaps, my team developed a statewide artificial intelligence in healthcare strategy and framework with the goal to unify our approach as a system in terms of how we want to harness AI across the state safely, effectively and consistently. And the approach to that was risk-based. So we don't want to stall low risk-based solutions. We want them to be able to flourish relatively unimpeded. But on the flip side, we also want to apply rigour and robust oversight over those higher risk solutions. So in all of this work, what remained front and centre of our executive steering committee's mind was a principles-based approach, and we used the quintuple aim of healthcare, or I think now they call it septuple with environment thrown in how we want to harness AI. So thinking about nuancing those pillars of the quintuple aim being equity, patient outcomes, patient experience, clinician wellbeing, and the financial sustainability, and the interconnectedness of all those factors when we decide to pursue an AI opportunity. And with that, we had specific strategies around clinician wellbeing and empowering them with the skills, the training, and the capability uplift to harness it. And from a patient perspective, how we can provide that flexibility, choice, rapid feedback mechanisms, and also the knowing when they are interacting with AI solutions in their healthcare delivery too.
I think the underlining principles that we're hearing here is work smarter, not harder. And I think one of the statistics I'd always have floating in my mind is by 2040, we're going to have double the number of patients, but we're not going to have double the workforce. So whether we like it or not, we have to work smarter and not harder because the workforce will not be there. So the wonderful buildings and hospitals that we design, the spaces that we create and the technology that we create is going to be redundant if we don't have people or models of care or services that support that in the long term. So what I think is coming is a really exciting opportunity, and that's why we called the program Smarter Hospitals. It's about how we can make our hospitals smarter in looking at things such as virtual command centres. It's about integrating technology in a useful way that can be measured in terms of patient outcomes and also clinician outcomes as well, but also that long-term sustainability. Most importantly, I think we're seeing out of this in the work smarter but not harder, is that change management principle. Having really good buy-in from executive with a clear vision, with clear measures of success, clear benefits, allows you to bring them along that journey. And I think, personally, I think that's a huge, huge advantage that we need to see as all leaders in this field, that if we bring people along the journey from the start to finish, we can really do that work smarter, not harder. And I want to end on a really personal note. I think all of us here have really come to it as a professional field. But whether we like it or not, our loved ones or ourselves will be in these facilities one day. So my late husband passed away from cancer 3 years ago, almost 4 years ago. He died at the age of 40, and he had a long battle with a rare form of cancer. So I just want to remind people that we are coming from this from a professional perspective, but also at the end of the day, we are a service industry. We are servicing the patients, we're servicing our community. And so to reflect that in the work that we do and the everyday changes that we can make and be change leaders in a way, whether it be small or large, is really important. So I really want to empower people to go back to remember why we're doing this in the first place. We're doing this for the people that we care about in our community and also our loved ones, and also ourselves potentially in the future.
Thank you for sharing, Anita. It's, I mean, that's off script for sure. So I'm speechless, but I'm speechless for many reasons. Like a great reminder about that everything we do it for patients. Of course, we do it for staff as well, because we are focused on human experience as a general, not only patients, but it's a great reminder. This panel discussion has, I think, put the spot on many issues we face every day. It has taken us a bit further away from the built environment, which is key and an enabler for providing healthcare. But without all of these solid grounds in terms of system and service, workforce, all the other enablers, even the most beautiful building will not be able to deliver the care we want to deliver. So thank you again. There was a final question, but I think you've said so much great things. I don't know if we need to ask key takeaways. I think you wrapped it up and summarized all the points so well. I know that many people will have lots of questions, so maybe we can extend a little bit the Q&A session and give it to the audience to share any insights or ask any questions.
That was magnificent. Thank you for your generosity in sharing the ways that you're forging new paths for healthcare. And as a health planner, one of the things that I find challenging is that I come with clients and they say, this is the way we've always done it, this is the way we're going to do it, we're comfortable with doing it this way, we'd rather not change. And I naturally defer to evidence and say, this is the evidence of what is happening and what works and the changes that need to take place. Can you tell me how the work that you're doing now will come into the public domain as evidence? Will it be as published papers or other ways that we'll be able to show our clients the directions and the dynamics?
I'm happy to kick off on that one. Thanks for the question. So in Queensland, we certainly recognise health service planning and capacity differs across the state. So taking a system-wide view of how we can build that capability to drive local health service planning, my team developed a guide to health service planning resource, which is actually publicly available to your question if you want to have a squiz online. And basically it's a step-by-step resource to guide someone who wants to undertake health service planning, or clinicians or non-clinical staff who are involved in health service planning, as to all the key processes and steps that they need to undertake when completing that process. So ranging from scoping the service planning activity, understanding the planning context, right through to the scenario and options development, key data elements and stakeholder engagement principles. So it endeavours to be a practical tool and, as you say, to drive that evidence-based approach to planning so that we have appropriate allocation of resources as well.
I might just make a very brief comment about AI implementation. What we've done in terms of our approach here with the South Australian Government and with our first 2 sites, so we've got 2 sites that are using this AI scribe, the Queen Elizabeth Hospital and also one of our urgent care centres at the moment, and then we move into 9 EDs across metropolitan Adelaide and into the regions, is we have done this as a silent trial whereby the AI tool runs in the background so that we have still the continuous way that people like to work, which is, entering the notes, and then we're collecting the data behind the scenes, doing a comparative study around the quality of the notes being generated, which is using a PDQ-9 score based on the US evidence of the quality of medical records, and then that enables us to do a silent trial comparison between the two. What we have found, based on very strong feedback, is that clinicians absolutely want the evidence of why they should change. They want to see the time saved of using the AI, and most importantly, people are concerned about privacy. They're concerned about their own data and information that the clinician themselves is using and saying in real time with the patient, but they're also worried, of course, about the consumer and the patient who has consented to this tool being used. So we build it as a silent comparison. It sits in the background. Silent trials are becoming very strongly evidence-based for AI tools in healthcare, and it helps us to have the confidence before we roll out into real-time live products, and that enables us to do 6 to 12 months of silent trials up front.
Morning. It's a great panel discussion, and I'll probably be careful what I say in a room full of people who are focused on designing buildings, but where I see AI and the digital technology going is actually keeping people out, keeping, as you say, care closest to home. I think the opportunities are massive, and when we review business cases, the first question we ask is, where are your non-infrastructure solutions? So I see that's huge. And so in that regard, I suppose I've got 2 questions. One relates to the conversation we had yesterday about how we bridge the divide that's created by the funding challenge we have between acute care and primary care. Obviously, electronic patient records will bridge that gap. But how do we, you touched on nurse-led practitioners. How do we make that transformation as a system-wide, given the different funding streams that we have? So that's sort of question number 1. The second one is around, I think I might use the New Royal Adelaide as an example. You talked about the nursing workforce and the amount of people that are leaving the workforce, and I think it's recognised that we have an ageing nursing workforce. And I know when they opened the New Royal Adelaide, there was a lot of nervousness because there was the nursing workforce in particular was suddenly introduced to a huge amount of technology. How do we manage that change when recognising the workforce, and I'm talking as a member of the older generation, how do we manage that huge digital change with a workforce that may not be as AI savvy as other parts of the population?
I think I have a answer to that. So we've been working with the Ministry of Health to address that exact problem, which is capability uplift. And I think the data is actually showing that that people who are in the older generations are fearful of the technology, but actually with the right training, you can see that AI and other supportive diagnostics, but also other virtual care modalities and other digital technologies, is not as difficult as they fear it to be. So it's about that change management of training and the right training for the right person at the right time. But most importantly, another thing that's coming into the fore is that retirement, which is what you're talking about, that ageing workforce. So we're working with a lot of the colleges, the universities, our TAFE colleagues as well in New South Wales, to talk about models of care and models of education in those curriculum and develop it early on. So the RACGP, so the General Practitioners College, is already doing a curriculum based on virtual health. So it's going to be coming into the curriculum and being embedded for that capability uplift, but it is a journey. And we're just at the beginning of it in terms of that AI transformation. But I think starting from the beginning, which is that education process, and also the training and the capability uplift, and also making it accessible, as you mentioned before, it's actually, the data showing us that actually people who do the training, embrace it and start using it are actually loving it and using it much more seamlessly than they first thought.
And I can quickly touch on the first point of your question around those funding differences. So to give you an example, in Queensland, we've established a joint regional needs assessment framework. And the idea of that is to bring together primary healthcare networks, which are primarily funded federally, and the hospital and health services in a joint local planning exercise, and that's recognising the need for cross-agency collaboration and that the needs identified through that process might not necessarily sit with certain bodies, but to help facilitate the establishment of programs based on need and bringing together those stakeholders through that process.
That's why the mic's travelling round. I think this piece around education is so critical of how we do bring about change. And I know I was at NYU Langone looking at their incredible facility there, and where they have embedded virtual nurses into the ward was just astronomical. And I asked one of the nursing team there, I said, how do you cope with having a virtual nurse coming in and delivering, subspecialty nursing care into the ward? And, they were contracting, workforce out from the Midwest to the US into NYU. And it was just fascinating. She said, we love it, because it's about actually working with the right skill set and supporting the patient for the care that they need at the right time. And if you can build that in virtually into your physical hospital, we've just seen the transformation. And I think it's helping people realise and understand and experience in real time is just so powerful to bring about change.
Thank you. It's been a fascinating panel to listen to. One of the undercurrents, I think, with virtual care and the escalation of that, which is almost a no-brainer in terms of how we respond to the current challenges we've got, is the ICT architecture across the state, for example, and the support of that, which I know that we are finding is not able to supply that, and it's part of the limiters. So I'm wondering from your states how you're dealing with that.
So from the New South Wales perspective, we're working really closely with eHealth. So we have a program called Single Digital Patient Record. And as part of that program, they have to do an ICT infrastructure assessment to address those concerns. So eHealth is a division that is concentrating and focusing very hard on that. But one of the things that we're doing is working alongside with them. So when we build our hospitals, we have an ICT team that look after that as well. But one of the things that we're finding is actually with virtual care, it's about the infrastructure outside of the hospital that we're most worried about. So particularly for our rural and regional colleagues. So I think there's a lot of work to be done about those, the accessibility, first of all, and those black spots that we're experiencing, that we all experience if we're not on certain networks, about accessing even Wi-Fi. So I think this is a broader question, and I think that's something that's really important that we need to address, particularly for our rural regional colleagues as well. So we're slowly getting there. We're looking at things like that for virtual care, and what we're doing is actually looking at particularly having hubs instead. So we might have a command centre, but let's just say if a patient is not well-versed in technology or is in a Wi-Fi black spot, they can come to a hub that is closer to them and get the care that they need.
I'll just quickly add, we certainly see it as a workforce attraction tool where increasingly more of our clinicians are wanting to be able to work in environments that do provide opportunities to utilise technology and digital tools. And a quick example, we developed a Queensland Health robotics strategy, and through that consultation process with clinicians across the state, we certainly identified that clinicians were attracted to work in places that offered them the ability to utilise robotic technologies in how they deliver care. So to your point around that disparity, that has that flow-on impact as part of our workforce attraction strategy as well.
Thank you so much. I just wanted to ask, I'm Kate Evans from Canberra. Just wanted to ask, as a clinician, I fully appreciate the direction we're taking with AI and with virtual care. But what I'm finding in the infrastructure space is it's virtual care ? So what does that mean? We start to do the functional planning briefs and we say, oh yes, and virtual care. And it kind of sits there, out there in the realm, because everyone's on a continuum of maturity to understand how virtual care is activated or not activated within a health system. So I'm really interested to understand the planning methodology that we should be starting to adopt in this space to consider how we future-proof our facilities to enable virtual care, both in the ward environment but extending out into that neighbourhood, health neighbourhood, where the patient's home is the centre of the neighbourhood.
I'll make a quick comment around some of the work, and particularly in Health Direct and My Health Record. There is an absolute need to think about virtual health as not an add-on, and that's the reality, is a lot of the time it is an add-on. And some of that comes down to the funding arrangements that exist nationally around how we are currently not funding virtual care versus activity-based funding, and how that sits in the health infrastructure piece at this point. But what we do know is that there is an absolute drive to change how the front end works in the system, and that's really the virtual front door piece of work with Health Direct, looking to see how can we enable care to be, within the home at the front end in a primary care capacity. And that's really the basis behind having 1-800 Medicare, was to centralise nurse triage support and a national perspective, and be able to then have each of the states then as shareholders of Health Direct, which enables us then to have GP care delivered in the home for patients using a virtual modality. The problem with that is it's not connected into the healthcare system. And so that's where it comes to My Health Record. Telstra Health are now, as part of the provider, are uplifting the capability of My Health Record. And then there's work, of course, around how do we have a health information exchange, which will then support information coming in that can then go and work collaboratively with other sectors and with other settings. And so I think from the perspective where we see the biggest challenge is how do we get agreement from each of the states that in fact this is the pathway forward, or the jurisdictions, ACT, this is the pathway forward. How do we make sure that we've got consistency, that we all use My Health Record in a way that's going to uplift and support, but at the same time we do know that patients are not getting the care they need in a timely way currently. How can we do this in a staged rollout so virtual care isn't an afterthought, and in fact it's built at the front end, and then it helps us to actually understand that right care, right place mentality and where we can deliver that care.
Great. Anything to add, Kathy and Anita? All good? So that brings us to the end of our session. We hope you had some valuable insights, and we left you with more answers than questions. I'm thinking we need to have a part 2 panel discussion about this topic, because we can talk all day about it, or at least clinicians and health planners who are really interested in this space. I'll pass it back to Pete, I think. Yep. Thank you again. Thank you.